This talk is about antiseptics in hand surgery. First and foremost, I'd like to thank those who funded this research and the hundreds of people who have supported the CIPHUR portfolio of work over the years. If you'd like to scrutinize any of these data or the papers, they're all available open source. Antiseptics in hand surgery is an important topic because we do a lot of operations. The NHS commissions more than 200,000 hand surgeries every year. That's more than the hip and knee replacements put together. And just like any operation, infection is the most common and costly complication of hand surgery. And for this reason, numerous bodies advocate the use of alcoholic chlorhexidine skin antisepsis to reduce the risk of infection. But this guidance hasn't been taken up by the hand surgery community at large. There are prevalent and perseverated concerns. One might call it dogma. They reside around the risk of fire, contact dermatitis, and burns beneath the tourniquet when using alcoholic chlorhexidine. And clinicians outside the hand surgery community have raised concerns over resistance of microbes to chlorhexidine. Many of you will know that most of the chlorhexidine products in the market presently are not licensed for use in wounds. And particularly in the hand, there are some eloquent structures like nerves and vessels and open fractures in some cases, where clinicians are reluctant to use alcoholic chlorhexidine. And at the time I started this work and noticed the heterogeneity of practice, there was no evidence to support the guidance of alcoholic chlorhexidine in clean surgery, which is the majority of hand surgery. So to address these several deficits in the literature and the widespread uncertainty, we realized that many portfolios of work were required. The first step was to ascertain just how big of a problem this was in the hand surgery community. We did this by surveying hand surgeons in the UK. We published our work in the Journal of Hand Surgery. And we showed wide variation in practice. The majority were split between chlorhexidine and povidone-iodine based antiseptics, some using aqueous and some alcoholic solvents. And whatever antiseptic cocktail was chosen, the concentration of the active agent varied widely again. Indeed, a sizable minority of surgeons were using other antiseptics or none at all. So we decided this was a big problem and we needed to solve it. Our next step was to go to the literature and try to resolve the uncertainty. This had largely come around because pairwise meta-analyses only allow you to compare two things at one time. So the most up-to-date Cochrane review at the time we did this work was unable to decide which antiseptic was best. But this can be elegantly resolved by network meta-analysis, which is a well-established but fairly complex statistical approach to pooling multiple treatments for a given problem. So that's what we did. We systematically reviewed the literature. We found 15,000 patients in 17 studies who had undergone clean surgery. And we extracted data on SSI in relation to the antiseptic used. The work was published in the Annals of Surgery and drummed up a mini storm, so far as social media in surgery goes, because we showed that alcoholic chlorhexidine was always better than povidone-iodine based antiseptics. And compared to the reference group here, which was aqueous povidone-iodine, the higher the concentration of chlorhexidine in the antiseptic, the better. And if you chose to prep your patient with alcoholic chlorhexidine 4 to 5% instead of aqueous povidone-iodine, then almost certainly the risk of infection was around half. So at this point, we felt that we had resolved the evidence void around clean surgery and provided an evidence base for these guidance. But still, many concerns in the extremity surgery community to be resolved. And we decided next to tackle the problem of resistance, because we felt it sensible to understand whether microbes were gaining resistance before we ran a very large study. The concerns around resistance to chlorhexidine is largely derived from the microbiological community, where they have observed multi-drug resistant microbes expressing efflux proteins for chlorhexidine, meaning that they can squirt out chlorhexidine that's applied to them and survive the environment. But it was unclear whether this was conjectural or indeed a problem for other microbes, particularly those pertaining to surgical site infection. So, through a systematic review of 80 studies, extracting data on more than 6,000 microbes over the last 40 years, we looked at whether or not microbes had gained resistance to povidone-iodine or chlorhexidine. We were principally interested in the amount of antiseptic required to kill the microbe. This is not the minimum inhibitory concentration. We're not interested in bacteriostatic effects. We want to remove these pathogenic microbes, and so the MBC was the metric we extracted. This work is not published yet, but here's a spoiler alert. At least for the last decade or so, and for Staphylococcus, the amount of chlorhexidine required to kill Staphylococcus hasn't changed over the last decade. And that doesn't matter whether you're talking about MRSA or others. It's a very similar story for Streptococcus species, whether you're talking about Pyogenes or Viridans or others. At least for the last 25 years, the amount of chlorhexidine required to kill these microbes has stayed the same. There wasn't enough data to look at povidone-iodine, but nonetheless, we were very pleased to resolve concerns over resistance to chlorhexidine. And that allowed us now to tackle some of the most concerning dogma around fires and burns. We did that through a multi-center prospective cohort study. A huge amount of support across 4 continents, 13 countries, hundreds of surgeons, recruited nearly 2,500 patients. This was in the midst of the COVID-19 pandemic also. They were consecutive adults and children having any operation on the upper limb distal to the axilla. These collaborators captured data on surgical site infection within 90 days and any adverse events related to PrEP. Since we started beating this drum about chlorhexidine in hand surgery, more surgeons are using alcoholic chlorhexidine, but still the vast majority are using inferior antiseptics. That's povidone-iodine in water or alcohol, or chlorhexidine in water. Still some people mixing antiseptics or using other agents. And this is important because the choice of antiseptic in elective hand surgery makes a big difference. This is a Kaplan-Meier plot for patients undergoing elective hand surgery. That's clean operations, things like carpal tunnel decompression and trigger figure. At the top of the y-axis, all the patients have had their operation. We observe them over time for 90 days, 3 months. We see that patients prepped with alcoholic chlorhexidine, ChloraPrep, their risk of infection is around 1%. That's compared to patients prepped with anything else, where the risk is about doubled. We observed something else that was quite interesting. Just like the in vitro research shows, alcoholic chlorhexidine exerts an antiseptic effect for a long time. The first patient in this group got their infection more than 2 weeks after surgery, compared to patients who were prepped with other antiseptics. They got their infections within a few days. Similar story was seen for emergency surgery. These were typically hand injuries like cuts and crushes, fractures, bites, and so forth, where aqueous povidone-iodine was once again the worst antiseptic. That's betadine. Around 6% of patients got an infection if they were prepped with this agent. Chlorhexidine of any formulation was about twice as good. But here's where the uncertainty lies. We had a very small group of patients prepped with alcoholic povidone-iodine, and there were very few events in this group. This would and could be compatible with a statistical anomaly, And we felt it was responsible to conclude that in the context of emergency surgery, the data are unclear, principally because they don't agree with the wider literature. Most pleasingly, we were able to demolish the dogma that these antiseptics, particularly alcoholic chlorhexidine, were associated with adverse events. In the 2,500 patients in the study, nobody was burned, nobody got eczema, and there were no fires. And this is a really important finding because if surgeons who don't use ChloraPrep, let's say they use another antiseptic, if they were willing to change to ChloraPrep, just for these 4 common hand operations, that's about half as much hand surgery as the NHS commissions every year, just for carpal tunnel, cubital tunnel, Dupuytren's and trigger finger, if they were willing to switch to ChloraPrep antiseptic, then every year around 1,500 patients would be spared SSI, and that would save the NHS more than £670,000 per annum. So over the years, the CIPHUR portfolio of work has, I believe, managed to resolve many concerns around antiseptics in hand surgery, but still there is uncertainty, particularly around the application of alcoholic chlorhexidine to open wounds, ones that may have nerves or vessels exposed, and how this may affect healing. And so the next step is likely to be a multi-centered trial of these antiseptics in hand trauma. If you'd like to know more or support this study, please do get in touch or sign up to the RSTN. Thanks so much for your attention.